few seconds. As usual, I have one colleague in each country, because we have people from about 10 countries watching us today. So I allocated a nice job for one colleague from each country to let me know once they can see us live. So I started receiving some text to say, yes, we are live now, which is good. Now we just need to share the page. Yes, I can see people from Turkey now, which is good. Right, so guys, if you can hear me and Firas, just type anything. Yeah, if you can hear, yes, I can hear you, Firas. If everybody else can see Firas, please just type. Yeah, because for some reason I can't share your screen. I can't share your screen on the app. So just myself at the moment. Yeah, it just says audio. Just says audio only. So that's mean I can't share your screen. Sorry guys, we tried this already a few minutes ago and all was okay. So we're trying again now. So just bear with us for a couple of minutes. No. Right, it's the crazy things again for us.
I know. I'm
Yeah.
trying to.
Yes. All right. Fantastic. Welcome.
Oh, okay. Welcome everybody. Hi Mahmoud, how are you?
All right.
We did it.
Yes, yeah. Because technology is not our bet, but we are good in other things, which is good. All right. So,
You're right.
yeah, nice to have you on board, and I hope things will get better in your side in Italy.
My pleasure, and hopefully things will get better very soon, hopefully.
Everywhere, inshallah. So, okay, so we'll have, hopefully we'll have a fruitful and nice and rich 60 minutes discussing cervical spine, which, as we mentioned before, it's quite big topic, but from the name, it's a masterclass, which means we'll go straight to clinical points and some research evidence behind. We have a plan for today, so we will focus on the screening process and patient classification or profiling. So this is the main aim of the session today, but also at the end, we might touch base some of the treatment modalities and do some critical analysis from the clinical point of view of when and how to use these treatment modalities. All right? Yes.
Yeah.
Excellent. So let's start with the word screening. What the word screening means for you, for us, from your clinical point of view. When you say I'm going to screen this patient, talking about cervical spine, what are the main key points? If you just start with a couple of key points that you always need to screen in your cervical spine patients.
Look, maybe I think it will be better start talking on the importance of the screening, because as we know, and as we know today from the literature, something between the 5% and the 20% of patient that has a NAD4, so a neck pain and associated disorder that comes from or originate from a medical or a serious pathology. The 5 or 20% of this clinical presentation normally are lost at the first visit. And sometimes, fortunately, a very small percentage of these patients, something around maybe less of 1%, has a very serious pathology. So we risk very bad sequelae for those patients if they are not diagnosed very earlier. So what the guidelines and the clinical practice, the good clinical practice say us is that obviously the first thing, and obviously is a statement of our profession, the first thing is to be sure that the patient is inside your scope of practice, so that really you can help him, and obviously he's in a safe position where you as a physiotherapist can help him. So the screening for referral process, it's obviously a differential diagnosis process where that need a very advanced knowledge, need expertise from the clinician, because we don't have a real firm rules or guidelines in order to do the differential diagnosis, especially in cervical spine. We will talk about it a little bit later. And require also some advanced clinical reasoning. So the real differences for OMPT physical therapy, so a physical therapist specialized in the field of musculoskeletal disorder, it's obviously his capacity and his skills in advanced clinical reasoning. And we will see that the subjective examination, it's maybe probably the 99.9% instrument tools that we use in order to screen patients.
Yeah. So I completely agree. History is a key. Is always a key in the screening process. So let's say a patient with a history of trauma. Definitely, there's a point that we all need to consider. But sometimes, do you think we need to rush and send a patient with trauma for an X-ray? Or do you, I'm talking about the practice in Italy, which is not quite different from the most of Europe, to be honest. Patient with history of trauma, is X-ray is a must?
Look, we have a very good, normally I don't believe, and I really criticize algorithm clinical prediction rules, because it's something outside the clinical reasoning, you know? It's something that is not clinical in reality. It's just research. But we have, in this case, we have a very strong instrument that it's a clinical decision rules that is called the Canadian Cervical Spine Rules.
Yes.
That is a very strong instrument. It's very simple, because it's a risk assessment. So we are looking for the risk factor that drive us to decide if this patient is able to rotate his neck safely, and then after the active range of motion in neck rotation, we can decide if the patient needs more a deeper assessment, evaluation by diagnostic imaging. However, something that we saw from the literature, we saw that there is some case reports that tell us that normally patient that has fracture after a trauma, they need weeks before having pain. So what I use the Canadian CSPI rule is not only a very straight rule, but I think that all the risk that you find during the process of this decision rule, it's very important to ask the patient all the time when you encounter a patient that has a neck trauma or head trauma. We know that head trauma is a very high risk factor for a lot of pathology, medical pathology that mimic neck pain. Maybe we will discuss about it later.
Yeah. So I'm just aware that we have colleagues from different countries, and sometimes the patient listen to the medical doctor most of the time rather than listening to the physiotherapist. You know what I mean? Because normally they come straight away to the medical doctor, which could be in accident and emergency department, and they give him or her a painkillers and say, okay, you need to go to the physio. I would say I'm a big fan of the Canadian cervical spine rule, to be honest, but sometimes I think we need to be more suspicious and we need to put safety first. So I have seen a couple of patients in my career who had a history of trauma, and they can move the neck, rotate the neck more than 60 degrees. And after a couple of months, so I send them to A&E. A&E gives them painkillers and said, just go home and take the painkillers. But they came back to me after 2 months, and they're still having the same symptoms, but also they had other sort of symptoms like headache. When I sent them to X-ray, I found a double fracture of upper thoracic and lower cervical spine. So I'm not saying every one of us, every one of you guys will have the same, but maybe you might need to trust our screening process, but we also need to have the courage to send the patient for more investigation if we are suspecting any bad things. Do you agree? Do you think what the same?
Absolutely. Obviously, as we said at the beginning, the prediction rule is a very proper and strong instrument, tools that we can use. But at the base of everything, there is our clinical reasoning. So when the picture is not clear, obviously the patient safety is always first. So we need to consider for sure more appropriate diagnostic evaluation like X-ray or CT scan sometimes, because there is a lot. There is some case report described in the literature where we had patient that had a whiplash. They go to the ER department, and the X-ray at the ER department did not found nothing. So after 8 weeks, this patient go to 2 colleagues in US, so to physiotherapists, that obviously evaluating the clinical picture of this patient, send him back to the ER, and 8 weeks later they found a double fracture. It's called a hangman fracture. So that he has a double peduncular fracture with a listhesis of C3 on C4.
Oh dear.
So the beautiful thing of our profession that is not mathematic. So it's our responsibility to have as primary care professional to have the knowledge and to be honest when we are not sure what we have, what kind of clinical presentation we have in front of us to put the patients in a safe zone before everything.
Yeah. So the takeaway message from the last 5 minutes is, guys, history of fracture, history of trauma, or at any point in the last few weeks, for example, we might need to send for scanning or X-ray just to be on the safe side, even though the Canadian cervical spine rule is there, which is quite good actually in the screening process, but we might need to be more we need to doubt the scenario in order to make sure our patient is safe. If we move to the next, go ahead.
Go ahead. We will discuss about it later, I think. Yeah. So no problem.
So the second point is patient with cervical spine pain, but is not. We can't see a clear mechanical nature. All right. How can we clear out? Let's discuss how can we clear out inflammatory origin of symptoms or visceral origin of symptoms.
Oh, sorry.
How can we clear out or rule out an inflammatory origin or visceral origin of symptoms for a patient with cervical spine?
Yeah, obviously, we have a lot of pathology, medical pathology that at first presentation mimic neck pain. We have lots of it. So the master pathognomonic clinical findings is obviously something called the transient neurological sign or symptoms that sometimes patient he is not able to understand that is something that is strange or risky, and sometimes is really transient, so it's just for a few days for the patient. So obviously the main capacity that we has to have is being able to keep information from the patient, so deliver and driving a proper history taking, an interview. So our skills, we need to improve also our skills in interviewing the patient, and considering the fact that we as physiotherapists, probably we are the only healthcare professional that spend with the patient more than the average time compared to the other medical or healthcare professional. So we have plenty of time to discuss with him and looking for something that obviously it's outside the box, is outside the musculoskeletal behavior or picture that the patient think to has, and when he comes to us asking help for neck pain, So for example, we found, maybe let's go ahead. We will discuss also about a lot of pathology can cause neck pain. We know that we can have the pathology of the arteries of the neck at the first several weeks, has also somatic visceral pain. So patient comes to you and complain of neck pain. Me and some colleagues from the Italian manual therapy group, the GTM, me in particular, my colleagues Filippo Maselli, we published some case reports on differential diagnosis. We found, for example, a craniovertebral congenital anomalies in a 40-year-old man with a congenital complete fusion or with the upper cervical spine with a basilar impression. So we did the odontoid process inside the Chamberlain line, compressing the medulla. So we have, and he comes to us complaining neck pain, for example. We has also damage at the ligaments, at the upper cervical spine ligaments can mimic neck pain, for example. We has also other pathology like systemic pathology, so rheumatoid arthritis. We had, for example, also tumor sometimes can mimic neck pain as well. So there is a lot of scenario. We need to build in our mind a lot of hypotheses, and just trying to rule out every one of those before to going through the objective examination of the neck.
Yeah. So I would say all what you have mentioned is definitely things that we can see in clinical practice, and some of our colleagues might say, so what shall we do? Because it could be different things. But the good news is we have our basic physical examination process, which is mainly active range of movement, passive range of movement, compression distraction testing, repeated movement testing. And if our physical examination does not provoke the symptoms or decrease the symptoms, this could be a strong indication that we might need to refer the patient. Do you agree with that for us?
Absolutely, but I'm used to, and this is another very important thing that we need as a profession. We need to build up this competence. Is deliver a proper neurological examination that tell us a lot of information. So I believe when I have the doubt and the history is not very clear in my mind, the first thing I do before the physical testing, it's deliver a neurological examination. So central neurological examination, cranial nerves examination, especially for the neck, is very important, and obvious peripheral nervous system in case of a compression of a root or a nerve along the trunk of the nerve itself, I mean.
Yeah.
So this is a very important point in my opinion. So I think that physiotherapists must be more aware and need to know very good these very important tools that help us a lot during the objective examination.
Yeah. So that's mean to summarize this point, guys. To rule out non-mechanical origin of symptoms, we definitely need to do our physical examination right. Sometimes we'll have some keys in subjective examination, like constant pain that does not increase with movement or position. That means the pain is always there. Pain following signs or symptoms of infection, like high temperature, sweating, night pain.
Infection of the high breathing airways is very pathological. It's it's an important risk factor, for example, for rupture of or softening of the ligamentous tissue of the neck, for example. This is important.
Exactly, and sometimes infection of the middle ear. So we need to, in our subjective examination, make sure, guys, we ask a general question about the patient's status, health status, and also we might need to ask specific questions related to symptoms or related to systems that might refer symptoms to cervical spine. So this is not we can't compromise this. It's a must. It's a must do for all of us. Yeah.
Maybe. So, can I add a little very important thing? At the same level of the neurological examination, another very important thing that physio normally don't do, it's the assessment of the cardiovascular parameters. That it's cardiovascular diseases or pathologies is at the top 3 causes of death in the general population. And the most importantly, symptoms, all the risk factors are asymptomatic. So hypertension and all these very important findings, it's asymptomatic. So patient doesn't know if he has any doubt of having some pathology or pain. And for example, hypertension, it's a very important findings that tell us also that there's a damage in a vessel, for example. So it's something that we has to assess routinely in our clinical practice.
Yeah, definitely. That's why our scope of practice is expanding now. So it's not just about the active range, the passive range, neurodynamic tension testing. It's also about understanding the blood pressure measurement, the findings of blood pressure. Assessment of cranial nerves is a key element of our physical examination from now on. And again, we always have the option of referring the patient if we are not sure, because not every patient with high blood pressure will have neck pain.
For sure.
Definitely, yes. So it's something that we definitely need to consider. I completely agree. But sometimes we need to calm down and don't be over cautious or over irritable when we see patient with high blood pressure, patient with lung problems, or asthmatic patient with liver problems. Sometimes they refer symptom to the right side of the shoulder and neck. So again, it's a screening, which mainly from subjective examination, but also doing our physical examination right. We have a question: how to differentiate visceral pain? I always, I always answer this question by saying we have two different ways to differentiate if neck pain is visceral related or not. The first method will cost you 2 or 3 minutes and zero money, and the second way will cost you about 2-3 weeks. It depends on the waiting list, but also will cost you up 100 euros or more. So do the physical examination. If you can see limited range of movement, movement can decrease or increase the symptoms. If you can find a general sign of mechanical origin of symptoms, I will treat this patient. I will examine and treat this patient as a mechanical patient. But all the time, I will keep in my mind that it could be mechanical and something else. So at any point, if the patient report to me that he has signs of visceral problems, like, for example, asthmatic patient might say, I'm having difficulty with breathing. Cardiac patient might say, yesterday night I have some sort of heart palpitation. If any sign came up, I will always have I will keep the door open to refer the patient for more investigation.
Yeah, for sure. The pain behavior, it's very important. So if we have pain, as you said, that has pattern that outside the mechanical or musculoskeletal domain, obviously it's something that need to make us suspicion on the clinical presentation of this patient. Moreover, we have also some questions. So it's called a process called system reviews. Yes. So we have some precise question that is based mainly on the pain behavior, and obviously that looks for the domain of a specific viscera, for example, for the cardiopulmonary system, for the gastrointestinal system, for example, for I forgot the name in English. I'm sorry. However, we have also good textbook for it, and it's or you can Google it easily. There is a proper list of questions built up by colleagues, especially Bill Boissonneau from US, or yes. Another very cool and great book is Pathology or Differential Diagnosis in Physiotherapy.
Good.
So, from a colleague from US. Good.
Yes, exactly. And we will add, there is already some references for our colleagues that they can check on PrimePhysio website under the learning materials for this live session. So far we covered trauma, history of trauma. We covered how can we screen patients with inflammatory or systemic problems. Now let's move to the cervical arterial dysfunction, or the CAD, which is quite hot topic. All the time it's a hot topic, because at the beginning, many years ago, it was mainly the 5 Ds and the 3 Ns. Yeah, if you have, and we have testing for cervical arterial dysfunction, which we used to call as a vertebropatellar insufficiency test, or VBI test, which is not clinically relevant, to be honest, from my point of view. And we have a couple of studies that have been published last year, questioning the validity, the reliability of this test. All right, how can we, from your point of view, what are the main signs that you can hear in subjective examination that will make you think about CAD?
Let me just say one quick things about this this topic, hot topic, as you said. We as physiotherapy, we are too much concerned and scared about vertebral artery pathology. So we have to consider that we have a lot of survey that looks at how the profession change in using technique to the neck, because the colleagues feel risky treating the neck.
Yeah.
So we have some country like Canada. In Canada, only 2% of physio feel himself confident in treating neck, and only 2% manipulate the neck because he's scared about damage the vessel, you know, the artery. Now, the physiotherapy research on this field, it was focused on the vertebral artery. In reality, we know that the section of the internal carotid artery is 5 times more common than the vertebral artery. And this one also is something that need to make us think about. We are too much focused on something that is based only on mechanics and biomechanics. Now, obviously, it's something that can happen, and it's something that for several weeks, it presents only like neck pain. So it's very difficult. Yeah. What we know is that many cardiovascular risk factor, it seems to don't be related in order to develop a risk for a dissection outside the hypertension. Hypertension is very important to be assessed. We know from studies from Lucy Thomas, a colleague from Australia, if I'm not wrong, a lot of studies published on this field. We know that those patients must be recognized by the so-called, we mentioned them before, the transient neurological symptoms. So for vertebral artery, the most common are symptoms related to balance, dizziness is one of the most common, and obviously neck pain and headache. And when they are associated, they has a very acute onset, and the patient doesn't recognize as pain, so something that he's never felt before. Those findings are very, they must lead the physiotherapy to increase the suspicion of having something that is not musculoskeletal. For the carotid artery, more typically, the symptoms, the transient one, the neurological one, are ptosis or weakness on the upper extremity.
Yeah.
So muscle testing, myotome testing, key muscle testing is very important in this case. So always history, and if you are in doubt, I think the first thing to do is the neurological examination.
Yeah, and we still have the option to refer for further investigation.
For sure, if you have only minimum of doubt, the first thing is putting the patient in a safety zone. So.
And Doppler ultrasound and scanning is quite good in identifying these patients. So to summarize, I would say, let's say, and please add to that if you wish. Cervical arterial dysfunction, we definitely need to check the 5 Ds and the 3 Ns. Yes, we still have to check these. But I would like my colleague to be quite calm and quiet and don't panic if the patient says I have dizziness, because dizziness is one of the 5 Ds. Yeah. So if we have dizziness, diplopia, dysarthria, dysphagia, and drop attack, to be honest, I will be more worried if I have the 3 on the middle.
For sure. It's a clear neurological sign. It's something that is outside our scope of practice. For sure. This is a patient that has to be referred as soon as possible to a medical doctor.
So
I want to just say something on the testing, because this one is another thing important. Sorry, I forgot it. Yeah, testing is useless. The screening testing for the artery is useless. We know that the accuracy and the diagnostic accuracy is a joke.
Yeah.
So, and we know that the rotating the neck, it put more strain on the vertebral artery,
more than extension,
just on manipulating neck of the patient. So it's a joke, it's useless. What we need to do is exactly what you said. So looking for neurological symptoms, but it's not only looking for the 5D or 3N, but is obviously looking on the history symptoms that together drive you to think about something that is not musculoskeletal for sure. And neurological signs and symptoms is very important, yeah, for sure.
Yeah. Okay. So to summarize, just so to move to the next point, we're talking about cervical artery dysfunction, or CAD, or some people call it VBI, vertebral insufficiency. We need to listen to the patient history, subjective examination, rule out 3Ns and 5Ds, and the symptoms will not be of mechanical nature. Yeah. So it's not going to follow the mechanical nature of symptoms where one movement decrease, the other movement increase, and so forth. Okay. So if we move to the next point, which is related to cervical myelopathy. And myelopathy is quite tricky point, because the term itself is quite scary, but not necessarily every patient with cervical spine or spinal cord stenosis at the level of the cervical spine is a red flag, right? So most of the elderly patients, they suffer from stenosis or myelopathy, particularly over the age of 60, yeah, because of degeneration of the ligamentum flavum, because of the osteophytes, that's always associated with age. So these patients will get this kind of irritation of the spinal cord, leading to bilateral symptoms, and also they might get disturbance of gait. Reflexes could be affected. But here comes a point. It's all about decision making, because if I have a patient who is 65 years old with obvious myelopathy, yeah, but he can survive functionally, he's okay. He just has this kind of limited movement, pain every now and again on the upper limb, a little bit of weakness. This is not a red flag, guys. We can carry on with these patients. And we have a very experienced colleague in the UK, Claire Stevenson. She's been working with myelopathy for the last 20 years. And she always have a very clear opinion about this. Refer for surgery if the symptoms is getting worse, is progressive. If every day is worse than the day before, in this case, surgery is mainly aiming to stop the progression. But otherwise, we still can do things for patient with myelopathy. What do you think? What do you think, for us?
I agree 100% with you. Only in case where the clinical picture show you very severe neurological sign or bilateral sign, obviously you need to send your patient to has more evaluation. But this point, it doesn't mean that he needs surgery. Most of the time, the conservative management, it's enough, and we can manage pain and function as well. But obviously, if the symptoms progress and go worse by time, for sure this patient is a candidate, probably, if the symptoms come very bad at the neurological point of view, to surgery. But as we said before, it's not a matter to having a symptoms in order to be scared about it. It's the clinical picture that drives your decision. And there, it's important to put maybe some how do they call it, category. So we need to understand that only few number of patient needs a quick and direct referral for emergency management. Most of them, we can just monitoring them, maybe do something very not it's just what I'm trying to say is just treating them at the very low level, so no loading too much, and maybe have another visit from a medical doctor just to know to be sure on what we are treating. But sometimes we can manage them also conservatively, and we can provide them good treatment and increase their outcome. Also, if they have a specific pathology like the myelopathy.
Yeah. All right. So to finish off this bit, we might have a little bit of fun here. So what we'll do is me and you will give some signs and symptoms for a specific patient, and then our colleagues on the chat will say yes or no. So yes, refer, because there's a red flag. No, keep, because we can carry on our physical examination with this patient. Yeah, just for a few minutes, and then we move to the profiling or classification process. I will make a start. So guys, your patient is a labor. He's a builder, and he had a blunt trauma straight to the back of the neck. Yeah, this is straightforward. Shall you refer this patient, or shall you keep? You can say yes or no by writing on the chat on the right hand side. I'm starting with an easy one. There's a bit of delay. Right. I think there's a bit of delay. Yes. All right. So a lot of yeses coming here. Okay, that's good. Yeah. So I'll start with the easy one. So your turn.
Yeah, I will something more tricky. If I had a patient that comes and he has some pins and needles on two hands, is that a red flag? So you need to refer your patient quickly or not?
So
Yeah.
needles bilaterally. Shall we carry on with our physical examination, or shall we say no? All right. So I'm still having a lot of yeses, but I'm not sure of this for the first one.
You're right.
Yeah. Okay. So not. Okay. So we're having quite a few nots here. So to be honest, I will carry on with physical examination for us, because
it depends. This is what the question is important, because obviously one symptoms alone, it doesn't mean nothing.
Yeah.
You need to weight every clinical or physical finding with all the whole clinical picture. So if those patients, this one with pins and needles bilaterally was your patient that has a trauma, pins and needles bilaterally, it's a risk factor from the Canadian CSPIRO. So yes, he needs to go to do a X-ray. Otherwise, I need to perform my probably my neurological examination to see if the function of the nerves are okay, or maybe if pins and needles are from other origin, or I need to collect more other information why this patient has the symptoms that obviously increase my suspicion, but it needs to be contextualized in the whole clinical picture.
Yeah. So that's mean, guys, calm down, listen well. All right. Complete your physical examination and clinical picture. And in this scenario, myself, I will start my physical examination with neurological examination. Just dermatome, myotome, reflexes, looking for any neurological signs. If I can see clear abnormality of the neuro examination, in this case, I might refer. All right. So good. So guys, this is number 3, and please, if you're going to respond, just say 3 yes. Exactly. Otherwise, yeah, we have a bit of delay here. So the next scenario is scenario number 3, and if you're going to respond, just say 3 yes or no. Your patient is 65 years old man, and he has a history of prostate cancer 6 years ago. All right. and he has been treated by chemotherapy and radiotherapy. Everything is okay. And today, he came to you in your clinic with cervical spine pain, right? But also he suffered from quite widespread pain across the spine. It's more than cervical spine, but also it's around thoracic spine and upper lumbar spine. The question is, refer or keep? And this is number 3. So we're having number 3. Yes. Guys, please make sure you write number 3, yes or no.
Yeah, but we saw where they start.
Yes, exactly. Yeah, we'll give it a couple of seconds. All right. So I'm just aware of time, so we'll carry on. So history of cancer, straight away I will be worried. Yeah, because I have seen quite few bad and dramatic scenario in my career with recurrent carcinogenic problems. So if the patient has history of prostate cancer and the pain is quite widespread, I will definitely, I will do a very little physical examination, but straight away by the end of the session, I will have a phone call to his consultant or medical doctor and say, guys, we need to have a look. All right. I'm not going to scare the patient and say, look, I think it's a cancer and we need to do this and that. No, I'll just make it quiet and nice and refer him for more physical examination.
Yeah, especially for the carcinoma, the metastatic tumor to the bone, it's quite it happened a lot of time. So yeah. It's a kind of very bad scenario to encounter in clinical practice. Honestly, in my case, I normally try to tell to the patient that there is something that it's not fit very well with your neck pain. So I will prepare a report for you.
Yeah.
And please bring the report to your medical doctor. And in the meantime, I will send an email or I do a call phone to the medical doctor.
Yeah, fantastic. So let's carry on then. So classification. I teach in the Middle East and in the UK and in other European countries, not in Italy. It's your territory, all right? So and it's
you're welcome to come, brother.
Sure, thank you. So it's always the same question for us, but particularly from our young colleagues. How can we start the assessment process, number 1? And number 2, how can we come up with a diagnosis? Everyone is obsessed about diagnosis, right? We need to give it a name. It's disc protrusion or it's myelopathy or what, we need to give it a name. Everyone is really, really keen to diagnose. Do we really need to diagnose for us?
It depends. What do you mean? But as you described to me, no. In reality, what the guidelines told us, especially the very recent literature about the topic of neck pain and associated disorder, once you ruled out severe pathology and specific pathology like radiculopathy or myelopathy. Now, at this point, the most important thing to assess is the prognostic factor. In order to understand if your patient has a NAD, it's called NAD1, so it's a mainly nociceptive patient, so with a very good an easy prognosis, or NAD type 2, where you need to evaluate very well all what it's called the psychosocial factor that obviously has a main role in the symptoms that the patient complain. So the most important thing at the beginning is just trying to understand how much the prognostic factor are playing a role in the symptoms complained by the patient, and then only then we will try to find with the physical examination, the assessing, some tests in order just to provoke tissue and see which one is painful in order to start trying to treat those one, but in the same time is not just a matter of treatment. Our management, it's a multimodal management.
Yeah.
So first of all, we need to educate and do some counseling to our patient. This is the main thing at the beginning. And then we have other instruments, other tools like manual therapy, like exercises, like counseling, like we have a lot of tools. So the main thing, the most important thing for our profession is just understand which one and how much of each one we need to use with the specific patient that we have behind us.
Yeah. So I'm 100% agree with that.
Sorry, in front of us. Sorry.
Yeah, no worries. So it's okay. I will give an example here. I checked the subjective examination. No signs of red flags. All right. So that's mean I'm done with my first level of classification, which is patient safety. Fantastic. Good. So second point, the patient has symptoms going down to the shoulder, arm, and elbow. Okay. Some movement, let's say movement toward retraction or extension, started to centralize these symptoms. I think this is a good news for us because it means it's a mechanical origin of symptoms. So I have two options here. Either I write down it's a cervical spine disc bulge, all right? Because normally disc bulge is one of the causes that can irritate the nerve root and produce peripheralized symptoms. Or I might say this patient has a mechanical neck pain with neural symptoms that respond to mechanical treatment, which was in the form of retraction extension or mobilization. So I still can write down what we call clinical impression, yeah, which is quite comprehensive. It will give us the opportunity, guys, to talk about the patient physical problems, but also to talk about options of treatment. So I know some of you might say we definitely need a diagnosis because of insurance purposes sometimes, because of it's a main way of communication with the medical doctors. But sometimes we can make it simple as long as we are clearing any red flags. So I give an example of patient with peripheralized symptoms that could be easily centralized with neck movement. Do you have a category of patients for us that you call them the mobility and strength and conditioning group, where patient who just need to increase the mobility of the neck and increase the activation around the neck, but they don't have a specific pathology?
But look, honestly, I'm not concerned about the disc at all, because
Yes.
if you see the literature about this topic, we know since 20 years that if you bring 1,200 patients and you put them in the MRI, all of them without any neck pain, without any symptoms, at 20 years old, 80% of 20 years old guys has at least one disc protrusion. So
yeah,
it's not a matter if he has a disc anomalies, but it's always, I believe what I do is basing all my choice on obviously the clinical picture. So if I have some symptoms along the arm, obviously the first thing is doing the neurological examination and see what kind of pain mechanism play with the symptoms of the patient. So we know that we has a nociceptive mechanism. We know that we has also peripheral neuropathic mechanism. So we have sometimes patient that has pain in the neck and in the arm without any loss of function in the nerve, but just because the nerve is painful. And the cause can be also from an inflammatory process, and or it's called a chemical irritation of the nerve, not only because a mechanical compression. And the other important thing that probably I was not I didn't explain in a proper way is the central sensitization or patient. So for sure, the pain mechanism is important, but again, it's not a matter to classify patient, just do mobility, just do manipulation, because what I do normally is just provide a multimodal intervention. So I'll do a lot of things based on my expertise, based on patient preferences, based on clinical presentation, based on expectation. So, but for sure, to all my patients, normally I provide a lot of talk, so education, a lot of explaining what is happening. I assure the patient a lot of time. I try to reinforce everything using a lot of contextual factors. And then all my treatment, most of them, will include some manual therapy, because patient, especially, I don't know in England, but in Italy, every patient comes to physiotherapist. Yeah. He's expecting that physio will touch him, So some manual therapy, we know that helps in short-term analgesia, so just reducing a little bit of pain and make happy the patient, probably. And for sure, a lot of exercises, not only in my clinic, I teach my patient a lot of exercises in order to empower my patient, to increase his self-efficacy. I will teach him how to manage his symptoms. So again, I don't think it's a matter of what I have to do with this patient. The expert physiotherapist, I think, is the one that is able to understand for the person that he has in front of him how much and which of all the tools that we have it's proper for this patient. It is not only the clinical picture, it's also the preferences, it's also the social environment, it's also the expectation of the patient, it's also his previous experiences, is also what he's looking for. There is a lot of factor that we need to analyze and put together and discuss with the patient, discuss all the way to the patient, ask him, he will answer to you. You need you need to share the decision with him. If you talk with him, he will help you in find the solution, what is best and what not.
Yeah. So it looks like it's a quite fascinating job. We have to love. I think all of us, we must love this profession, to be honest, because it's very, very interesting. You will never get bored if you just enjoy the assessment process and enjoy the treatment process and keep thinking and rethinking and keep reflecting on what you do, and always expect good things, but also be ready for bad things. Yeah. So it's quite fascinating job, isn't it? If we think about cervical spine patient, particularly old people, there's a big quite wide range of colleagues. They always scared from moving an old neck, yeah, because we're being told from unknown sources that if the patient has osteophyte, if the patient has osteoporosis, don't move it, right? Keep it within the available range of movement. Don't go into the pain. Don't challenge the pain. How do you feel about that? Particularly, you are really into manipulation and you are a big advocate of movement.
Look, I think again, it's not a black or white, but it's always about, especially in older people, the comorbidity that he has. So once I arrived to a treatment decision, it's because I exclude and rule out all dangerous things. Otherwise, this patient will never arrive to be treated by myself. So the other important maybe topic to introduce now is the loadability. So another very important thing that we need to be able to do is always understand the irritability and the loadability of the tissue and the person as well. So every kind of treatment can be, do you say in English, dose?
Dosage, yes.
Exactly. So
Yeah.
you can select the dosage of every intervention you do on him. So I honestly I'm not I will never say in a just only don't touch old people or old patient. I myself I do manipulation on old patients sometimes. Obviously with some I will select my patient obviously, and again
Yeah.
I'm treating them because I'm sure that you will never be sure for sure, but if he is if he is on my treating table, it is because I exclude all the risk before. So again, I'm not the one that I will say black or white, yes or not.
Yeah.
It's always based on the person that you have in front of you, and the decision is made obviously excluding all the risky stuff that can damage the patient for sure. But if you are confident and the clinical picture is not raising any suspicion, why not? You can provide some technique that has some impulse. We know if you are an expert in manipulation, that your force is zero. So it probably is more risky putting pressure, mobilizing him, than just provide a quick thrust. Obviously, I will avoid treating some structure like the rib because it's risky, but I will avoid manipulation, but as well mobilization at ribs, because I think it's always a matter of dosage, not the technique itself.
Yeah. I think we will never go wrong as long as we do our screening right. We apply any technique, whatever technique we use, we apply it slowly, gently, and we keep communicating with our patient. So I don't think doing some mobilization or mobilization with movement or even manipulation according to the screening process, we will never go wrong as long as we are covering the main safety issues and we always keep communicating with our patient. One of the common issues that I see in my teaching, that we are so aggressive. Sometimes you are so aggressive. So we always consider that the patient is happy with what we do. So this communication point, I think we need to consider the quality of our communication with our patient. When we say communication, everyone think about communication as our language that we use in our subjective examination. The assurance and education strategies that we use with our patient. Very important part of the communication, guys, is when you apply a technique, make sure that you keep communicating with your patient. How's that? How's things going? How do you feel? All right. Is it too much? Can you? Shall I calm down? Shall I back off? And we explain to him clearly why we are doing this technique and what is the expectation from this technique. So I hope this point is covered now. So we talked about being brave and do movement as long as we are clearing the red flags, and also as long as we are communicating well with our patients.
And if you are scared, just be gradual, as you said.
Yeah.
Start with very gentle stuff and see if what the patient answer to you.
Yes. So another common word that we use is the word inflammation. Yeah. So what kind of tissues in the spine can produce symptoms? All the tissues around the spine can produce symptoms. So all the ligaments are innervated. The facet joint innervated. Intervertebral disc, the outer third, is innervated. The nerve root is highly innervated as well. So sometimes we use the word inflammation or tissue inflammation in a wrong way, or in a way that will scare us. When would you say that the tissues are inflamed or not? Do you follow the time scale, which is few days, 48 hours, 7 days, or do you follow the symptoms? order to make judgment if the tissues are still in inflammation process or not?
The only concept that I use with the inflammation, so you are talking about just the unload resting in this manner, or what do you mean exactly? Because I normally, when I have pain, we know that pain is something very complex. It's not just about inflammation.
Yeah.
So what I'm used to talk is about the mechanism of pain, that is nociceptive pain, that obviously it has inside the inflammatory process, but it's something that is physiologic, because pain itself is something natural on our body. It's just an alarm because we are threatening a tissue or a region of our body to damage. But otherwise, at the cervical spine, I don't talk too much about inflammation. I just see symptoms.
Yeah.
And you know, the imaging and our physical examination is not accurate enough or reliable enough in order to find the pain generator of the patient's symptoms. We know that we called all the most of the musculoskeletal condition is called non-specific, because it's impossible sometimes, most of the times, it's impossible to find just the tissue that is the cause of the patient's symptoms. So I think, look, I see my job very easy, because what I can do to my patient is just reduce the pain and improve the function.
Yeah, exactly.
So it's very easy.
Yeah.
I have a lot of tools that I need to decide which one is better for my patient and use them. That's it.
Yeah, and I think we also must be brave enough to.
Yeah, for sure.
To load.
We need to load patient as much as you can. We know that load and activity and active treatment is the best way to improve and prevent musculoskeletal pain, and also if he's an active lifestyle, a lot of other pathology.
Yeah. So yeah, definitely to be brave is a very important skill in this job, to be honest. So if I have a patient who's highly irritable and having high level of symptoms, the severity is high, we still have other things to use. So guys, it's not always about starting active treatment from day one. Yes, we must encourage the patient to start active treatment from day one. It's not about mobilizing the patient. Yes, we can mobilize the patient using low grading, and we have the lateral gliding techniques. We have the retraction, which is quite interesting one based on the work of Robert McKenzie and Stephen May. But also we should not forget the other tool that we have in our toolbox, soft tissue management. So this nice little dry needle on the upper traps or the occipital muscles or the short neck muscle, paraoccipital muscle of cervical spine, sometimes can help to calm down the involvement of the soft tissue. And things like neural gliding are always successful to calm down the neural pain and improve the mobility of the neural tissues. So we should not all the time just focus on one aspect of the treatment. Try to use the wide spectrum. Try to explore this big spectrum of management or treatment tools that we have in our toolbox according to the patient's symptoms. So the takeaway message is be brave.
Yeah, and those properly your intervention.
Yes. Good. So I think we can go ahead with some questions now. We covered two main important things: the screening process, and also we talked about different options of treatment, and we related this to our to different kind of patient. So we will be happy to receive any questions from you guys now, and please make sure the question is related to these two main points: screening process and treatment choices. Somebody is saying Graston technique. Guys, when we talk about soft tissue management, use whatever you wish. We are not with or against. I am talking about myself. I'm not with or against any. By the end of the day, it's a soft tissue, and the soft tissues always respond very well to any kind of technique we use.
Exactly. Because it's not. Sorry, just one thing, Mahmoud. I interrupt you. Sorry. We need to stop thinking this technique is better than another, because what we do, we don't know what in reality. We try to demonstrate that one technique is better than another, and still right now we doesn't know why some techniques is working on our patient. So just we have the good thing that we has a lot of tools. Just decide with the patient which one is the best for looking a good outcome.
Yeah, exactly.
That's it.
I think we wasted many years of our life comparing between one technique. Yeah. And what we know very well that we have our clinical bias towards some techniques. Even the researchers themselves will be biased, just unconsciously biased toward one technique more than the other. That's why they will start to investigate the effectiveness of this particular technique to others. Yeah, right? So let's calm down and just think about our treatment package as many tools. Definitely the most important tool of our treatment package is exercise. Let's face it. If we add exercise to other modalities, you will definitely get a much better treatment outcomes. But if you're just comparing X technique to Y technique, we are going nowhere.
You're right.
So our first question, would you like to go or shall I take this one?
I have plenty of time, I'm in quarantine, so I cannot move from my home. Yeah. And probably you are the first person after 48 hours that I'm talking with. So let's have another half an hour, no problem.
It's a pleasure. So how to assess cervicogenic headache and management? This is a massive, big question, but I will make it simple because I consider this is quite simple. If the patient headache increases or decreases with cervical spine movement, and yes, we have different testing for cervicogenic headache, but I always consider the movement as a key indicator of cervicogenic headache or non-cervicogenic headache. If movement of the neck increases or decreases the headache, I would say my provisional hypothesis, yes, it is cervicogenic headache. My second step will be to apply few tests, and I'm quite biased, and I have to say I'm biased here to simple things. So things like moving C2 over C1 and constantly, let's say for 10 seconds, and observe the change on the headache. This another it is subjective, but clinically it is objective sign. And also we have the work, we have too many other testings that we can use. But generally speaking, all the testing that we use is based on movement. If the movement increases the headache or decreases the headache, so it is cervicogenic headache. In terms of management, we have C2 mobilization, C2, C1 mobilization. It's always successful. But with headache patients, cervicogenic headache patients, they are not my piece of cake, because some of them, they respond very well, and others, they need more time, and they need to engage with self-management for a good period of time before they observe a good improvement. What do you reckon for us?
Look, since a few years, I start to ask myself too much if it's a pure cervicogenic or migraine or tension type, because the reality, it's very difficult to put tags on patient, But what I saw in the literature is that in the last few years, we have a lot of study that demonstrates that migraine and tension type headache patient has lots of musculoskeletal impairments. So the point is that one. Obviously, I need to categorize the headaches with the goal to understand the prognosis. So how much I can help my patient if I will treat him.
Yeah.
On the other hand, I will assess him. I will see if he has any tissue that reproduce his headaches. So I will use mainly provocative test. I want to see if I can reproduce the headache patient test, the familiar headache that the patient complains. Sorry, and then I will just provide a treatment in order to reduce the irritability of those tissue and see, based on the headache's characteristics, how much the symptoms change. If I have a patient that has pure musculoskeletal presentation, so something like you described, something very related to the neck, I'm expecting that the improvement will be probably very good. Probably the headaches will go. If I will find a patient that has a primary headache, I will just try to reduce any nociceptive afferent in order to see if the system calm down a little bit. And in the meantime, if I see if some characteristics of headaches like duration, frequency, and intensity will change by time. Obviously, importantly, and most importantly, it's important in those patients also see the general health and lifestyle. For example, we know that for migraneous patient activity, aerobic activity, it's very helpful in reducing frequency. So there is a lot of things to look at, but I think that we can help also primary headaches a lot, because obviously our goal is not to cure completely the headache, but just trying to help the patient to manage the clinical presentation of the headaches.
Yeah. So we definitely need to have an outcome measures, and the self-reporting outcome measures are quite important here, as you mentioned. Frequency, intensity. We need to listen to the patient and consider what the patient says as an outcome measure. So yeah, definitely. Second question: does shoulder pain like impingement can lead to cervical spine problems? This is quite. There's no
dangerous question.
It is. I would say I will follow my physical examination. I will follow my subjective examination and my physical examination findings. So if movement around the neck can increases or decreases, movement around the shoulder can decrease or increases the neck movement, I might consider that. It's highly unlikely that symptoms from the shoulder refer up to the neck unless there's a neural involvement. Yeah, this again, I could be wrong, but this is what I always seen. Impingement, which is quite big umbrella term, I would say I would replace the term impingement, if you don't mind, my colleague George Salah. I would replace this with the term rotator cuff tendinopathy. I don't think rotator cuff tendinopathy will refer symptoms up to the neck. But if there is any sort of positional fault, what we call a positional fault, or something wrong with the alignment of the shoulder due to muscle problem with the muscle harmony, for example, like big minor is dominating the around the shoulder area, or the external rotators are not doing their job, we might end up with some compression on the brachial plexus, on the big three nerves around the axilla, and this might decrease the movement of the axonoplasm. And here we can see some neural tissue, neural symptoms going up to the neck. Otherwise, but again, all what I'm telling you now is just a theory based on what we know from the anatomy and the biomechanics. But the physical examination is the key point that I will follow. If moving the neck, moving the shoulder, increase or decrease, or neurodynamic tension test is positive, I would say yes, the pain around the neck is related to the shoulder. But in this case, is not related to the shoulder, it's related to the nerves around the shoulder. What do you think for us? Would you like to add to that?
No, I 100% agreeing with you, but I think to the colleagues, George, yeah, look, I think I know it's 10 years that I'm teaching. So I know that all my students, what they want from the structure is having answer to a typical clinical picture. The reality, when you treat patient, is impossible to having something that is always wrote on the books, you know. So the most important thing, as Mahmoud said, is clinical reasoning. So history taking at the beginning, and obviously testing and see what correlates with the symptoms of the patient. That's easy. Nothing more than that, I think. So yes, potentially, why not? Tendinopathy of the shoulder can be related to neck pain. Yes, but there will be in the middle thousands of reasons why. And the only way that you can, it will be useful for you in order to decide which the best option management for this patient is assessing him and see, and based on your physical examination, see what reduce the pain, or see what the structure that are involved, and then manage the structure and see what change after the treatment. That's it.
Yeah. Great. So let's move to the next one. I'm not sure if this is a question or a statement. As a physical therapist, I should know everything about pathology which may affect our cervical region. Okay, it depends what do you mean by everything. But again, it's all about the screening process and understanding which systems can refer symptoms to this specific area. So if I'm dealing with pain on the buttock, definitely I need to be aware of different systems that can refer symptoms to the buttock, starting with the uterus, if I'm talking about a lady, prostate, neural tissues, femoral nerve, sciatic nerve, hip joint. So it's all about this kind of differential diagnosis, and sometimes we end up with a process that we call diagnosis by exclusion. Yeah. So I think we might look at other questions. This is another.
Yeah, but in the meantime, I think it's very important that physio, especially if they work in a direct access setting,
Yes.
need to improve a little bit the knowledge of this pathology.
Yeah.
So, obviously, you are not a medical doctor, so your diagnosis is not a medical diagnosis. But as Mahmoud said, it's important also to have any competencies and tools in order to exclude something that is outside your scope of practice.
Yeah. Next question, your turn, Firas, if you wish.
TMJ problem can affect neck mobility. This is a good question, but again, there is not a yes or not. I'm trying to remember some article on that. For sure, there is a lot of relation between TMJ, so temporomandibular joint, and neck. But honestly, now I'm trying to remember. I never read any paper that demonstrate a clear relation between the problem of the TMJ and neck mobility. But for sure, what I do in my clinical practice all the time when assessing the neck, I'll assess the TMJ. I'll assess a lot of time also other system of the face, so the ocular movement. I'll assess the masticatory muscle. I assess the TMJ. Obviously, it's always when you assess the patient, your job is trying to do like Sherlock Holmes, look around and see what clinically can result important to the symptoms that the patient complain. So yes, I'm used to assess frequently TMJ when I'm treating neck patient. Yeah.
I will answer this question by asking a question. So if you know from the patient history that TMJ is problematic, so like the patient has a problem with the disc of the TMJ, or he have a problem with the opening or closing mechanism of the TMJ, and at the same time he's suffering from cervical spine stiffness or pain. So I will put two different hypotheses here. First one, the patient has two separate problems, cervical spine and TMJ, or it's mainly TMJ, but because of the compensatory mechanism and the pain, he started to get this kind of secondary cervical spine problem. So as physiotherapists, we always think about the management, the treatment. Yes, assessment is very important, but based on these two hypotheses, I follow the treatment-based diagnosis model. So I will move the neck. I will either mobilize the neck or manipulate the neck if needed, but mainly I will go with mobilization first. If the symptoms around cervical spine have decreased with mobilization strategies or soft tissue modalities or both around the neck, in this case, the patient has a cervical spine problem and I'm treating it. But I still need to consider the TMJ, and we have other things that we can do for the TMJ, including mobilization, including relaxing the masseter muscle, including self-management exercises to maintain the angle and the mobility of the joint. So always think about, is it primary or secondary? And instead of thinking about it that way, think about it, is it one problem or two problems? If it's two problems, I will treat each one separately. If it's one of them referring to the other, I will focus on the one that's referring the symptoms. But again, it's just a clinical, it's all about the clinical reasoning again.
Exactly. I will answer to you with the question. What will change with your management if you know that is two different problem, or one is secondary to the other at the end of the story?
Yes.
You're basing your treatment on your physical examination, so the treatment will be the same. It doesn't matter.
Yeah. Exactly.
I'm treating what I'm doing. I'm looking for impairment and treat them. That's it. And then I will inside this box I will put also a lot of tools like exercises, like education, like self-treatment, like. So what I'm doing with manual therapy, I think it's very difficult to state this one is secondary to the other one. It's reasoning. You can hypothesize, but obviously your treatment at the end of the story is based on your assessment.
Yeah. The next question is quite interesting. Is it possible for cervical spine radiculopathy to produce swelling of fingers, finger swelling?
Yeah, this one is a very good one.
Yeah. Okay, so I will give a scenario here. This is one of my patients. She used to have radicular symptoms all the way down to the fingers, and she wake up at night every time she sleeps on the right side, on the affected side, and in the morning she gets this kind of swelling of the hand and the fingers, not massive, but not again, she feel it, she can feel it. So ruling out any vascular origin of symptoms. So vascularity was okay. Yeah, no problems with arteries or veins. Blood pressure was okay. No signs of lymphedema in general, which is quite rare. But again, we need to check it again. I would say sometimes if there's a sympathetic involvement, it might produce this kind of, autonomic nervous system involvement. It can produce, sometimes can produce swelling. I haven't seen it with too many patients, but it can happen. And the only way to know if it's related or not is to screen any vascular problems, number one, and to monitor if there is any change on the swelling with the improvement on the other symptoms. So if the patient neck pain and neural pain on the arm is decreasing, but also swelling is decreasing, I might relate the swelling to the radiculopathy or the neck problems up there. Yeah. So this will be my answer. Any comments for us? Any addition to that?
So it depends, because also radiculopathy is something weird in the literature, because there is a lot of way to define it. So obviously the most important definition of radiculopathy is the fact that we has any changes in the function of the nerve. So we need to have some neurological findings. So reduced sensibility, reduced force, or changes in the osteotendon reflexes. Per se, a radiculopathy, I'm looking. It looks very difficult to can cause swelling in a finger on the finger, but obviously a pathology that can indirectly, as you said, provoke other mechanism that can explain why associated with it.
Hello? Can you hear me, Frost?
Yeah, I'm there.
Yeah. Right. So I think we have time to take one more question. I think it says it's already 90 minutes, 91 minutes. So is manual therapy doing any mechanical change in tissues, or it has only neurophysiological effects? That's a good question that has no answer, because it depends on in which camp are you sitting. If you are sitting in the Australian camp, where everything about the pain in the brain, it's all about central sensitization, it's all about education, and manual therapy is a scam and it has no effect, then the answer will be yes. If you are sitting in the other camp where people use their hands all the time and they always claim that they can change the mechanics of the vertebrae, they can turn the vertebrae by 5 millimeters or 5 degrees, and everybody knows what I'm talking about now, all right? You will say it is mechanical, all right? So I would say it's a bit of both, because increasing the range of movement is a mechanical effect. And to be more brave in doing the movement is a neurophysiological effect, because the endorphins is coming down to say, go for it, you can move your neck, don't expect any damage. This is a neurophysiological effect, but also increasing the range of movement, improving the quality of movement is a mechanical effect. So I think it's a bit of both. And we must cheer up, guys. We must be happy, because as long as the improvement is happening, the patient is feeling better, who cares if it's about the mechanical effect or the neurophysiological effects? The patient is happy and you have $50 in your pocket. That's it. All right. So this will be my answer for this question. What do you think? And I think you have a big issue with osteopathy in Italy at the moment. So
Yeah, no, it was
talk about it.
no issues. It's look, the answer. It's I fully agree with you. The reality is that we don't have any tools that is able to directly measure what it happened after manual treatment. We have a lot of hypotheses. For sure, there is a lot of players inside the mechanism. For sure, we will have some neurological effect. For sure, we will have some mechanical effect, probably, because we are putting force on an external body. So there is for sure some mechanical effect that probably it's the starter of all the neurophysiological effect. We will have mechanical changes after the treatment. We don't know if it's directly directed to the treatment or not, but it happened. We have also a lot of contextual factors, placebo effect. We have a lot of things that play together. We don't know why still. We have a lot of hypotheses, but as you said, at the end of the important thing is, if I provide an intervention and the result is an outcome that I'm expecting to provide to the patient, so I don't care. It's fine. It worked. So if the patient is happy and the symptoms are reduced and he moved better, I don't know if it was because I told him that the technique is the best one, or because I'm the best one in providing manual therapy, or because the patient was expecting that, or because my force applied on his body provides some neurological effect, or all of these things together, for sure. But at the end of the story, what we do normally is just expose the patient to a treatment and see if the outcome that we are assessing is changed after the treatment or not. So it's treat and assess and see what happened.
Yeah. Next question will be the last question, which is, I think it's related to, we already covered this before. How do you choose technique for neck pain disorders is quite open question. I will choose a technique based on the physical examination findings. So if my physical examination findings reported positive neural tension test and the patient has neural symptoms, I will go with neural gliding. If the patient has nerve root compression or irritation, I will go with neural gliding and mobilization strategies for the neck. I will definitely all the time must include muscle activation strategies like deep neck flexors, and we have an enormous amount of research about the effectiveness of deep neck flexor activation for patients with mechanical neck pain. So again, it's all based on your physical examination findings and your clinical reasoning process and the patient response.
Exactly. Look, there is not the magic answer for all the patient.
No.
So I honestly, there is technique that I prefer compared to other. Matteo is a friend. It's a colleague from Italy. I know him, and I'm saying ciao Matteo. Thank you for the question.
Yes.
I'm used to prefer some technique for sure, because I'm an expert in them, because I feel confident, because I know that patients that come in my clinic to see me because they know that I'm good in something.
Yeah.
So obviously, every clinic prefers some technique compared to others, but the choice is built by the physical, obviously the assessment from the subjective to objective examination, and then the preferences of the patient for sure, and obviously depends on the mechanism of pain and the goal. Why do you apply technique? So as you said, if I have to reduce the sensibility of a nerve, I will use some gliding. If I want to treat, if I'm provoking pain, I will provide the manipulation. If I see an upper trap that refer pain somewhere, I can do some massage or dry needling. The important question is not which techniques, is the goal. Why are you treating something? And you will have the technique that you need to use.
Yeah. So we can keep going for another couple of hours, but I think this is the end of the session. For us, I really enjoyed this discussion, and I really enjoyed the questions and the engagement from our colleagues. Our statistics say that we had physiotherapists from 13 countries, which is good, which is great. So we have a wide range of education background and professional background here. So next live session, guys, will be next Friday, 10th of February, 10th of April, same time at 8 p.m. And we'll carry on with the discussion about cervical spine. If you have a specific question, get ready and join our next live session on Friday with my colleague Juan De Leo Rizok. And looking forward to see all of you. For us, it was great to talk to you as usual.
It was my pleasure. As iPhone background, I think it's important. Also, it's our responsibility to share knowledge to colleagues. So I find it was my pleasure, and I'm happy to see you very soon in Italy. If you are welcome whenever you want it. And thank you to all the colleagues that follow us tonight and was so keen to follow us till this late time.
Yeah. Thank you, everyone. And thank you for us. Stay safe, everyone. And inshallah, looking forward to see you next Friday.
Sorry. Thank you to you, Mahmoud, that you invited me, and to PrimePhysio UK as well.
Thanks for us.
You are doing very well, especially in our region. Both of us, we are originally from the Middle East, or north of Africa. We need to provide some knowledge from new science from there. So thank you very much for what we are doing.
You're welcome. Thank you. All right. See you.
See you.
Bye. Bye.